should I just hit it? Yeah, good afternoon, everybody. Show of hands, who has used ultrasound to evaluate the eye, ocular complaints?
Awesome.
Probably almost half, a little less than half. Okay, so when we think about point-of-care applications, ocular ultrasound is actually now in the scope of practice for our registrars, for our resident doctors. And just like all these other applications, it's a very focused question. Is there something in the vitreous chamber, yes or no? And that's about it. But what we know and what you've read is there are many more ways that you can use point-of-care ocular ultrasound. And I'm going to show you some cases to illustrate some of these. So this is a normal image, still image of the eye. And if we were to actually apply some anatomic labels, your probe, which is the high-frequency probe, is on a closed eyelid. And the first layer you're going to see is the cornea, followed by the anterior chamber, the iris, and then suspended will be your lens. That chamber, which most of us call the posterior chamber because it's posterior, is actually anatomically not correctly the posterior chamber. If you remember, the posterior chamber is in this area right here, where people can develop their acute glaucoma. But this is correctly called the vitreous chamber. And then followed at the back are two layers that we don't see unless there's some sort of pathology, which is the vitreous and the retina. So this is one of my registrars who's allowed me to demonstrate. This is how I prepare the eye for ultrasound. We put a tegaderm, sort of a barrier, make sure that you wrinkle out all of the air bubbles. And then I have the patient, or in this case my registrar, turn to the opposite side so that gel doesn't fall down into the side of their face. So she's going to turn her head a little to the left. And there you'll see, I'll see Surgilube. There's absolutely no evidence to use Surgilube in a protective barrier. It just feels more right for the eye. And in fact, you'll see cases and papers published where they just have a person close their eye, put regular gel on, and that works too. This is a little bit nicer and people don't feel all blurry-eyed after the fact. They do feel like they've got a little bit of depilatory though when you remove the tegaderm. One of the things I want you to note is, you know, people are often in pain and people are very sensitive regarding the eyes. So I will say, listen, you're going to feel my finger on your nose. You're going to feel my finger on your cheek. You're going to feel me touching your cheek. This is the coronal plane that we use when we're actually looking for pupillary light reflex. You can also use the probe and hold it from above. So there's all different angles and planes, but as with all these, you're looking in two planes. So of note, most of the machines that you'll be using actually have an ocular setting, and this goes back to safety and power outage. There's been no adverse reported outcomes of using ultrasound to evaluate parts of the body, but the thought is over time there's thermal energy that's transferred. So ideally you don't want to just be scanning eyes all day and have and keeping your probe on and keeping all this energy. And if the machines have an ocular setting, you want to be sure to use the ocular setting. So, you know, very common chief complaint and patients that we have come into the emergency department is patient with eyes swollen shut. So there's a lot of things you can tell through a closed eyelid. And one evaluation is something you're seeing here. So what exactly are we seeing here?
It's moving.
It's moving, right. So a patient with a painful eye, a patient with an eye swollen shut, you can actually say, look to the right, look to the left, look to the right, look to the left. And then you can change the plane of your probe from a transverse to a sagittal, and you can say, look up, look down, look up, look down, and you've now evaluated your extraocular muscles. Okay, does it evaluate the difference between a partial entrapment versus a full entrapment? No. But you can see whether or not the eye is maintaining its anatomical shape and form, and you can also see if the muscles are intact. A word on the literature regarding point-of-care ultrasound in the eye. There's sort of a rite of passage for almost all literature, and it's not just ultrasound, it's also emergency medicine. Like initially there's sort of letters to the editor about, you know, point-of-care ultrasound. Then there's a case report, then there's a case series, then there's a retrospective chart review, then there's a prospective convenience sample. And most of the literature and most of the published research that we do are convenience because it's when we're conveniently working in the emergency department and enrolling patients. It's very hard to do this research, and it's why you don't actually see a lot of randomized controlled trials, or we're not yet at the level of research in terms of quality of randomized controlled trials. There are a few, if you think about the Stone protocol and, you know, colic, there are a few, but we're sort of maturing, I guess, from adolescence into early adulthood. All right, let's get to some cases. So a patient is presenting to you with a painful eye. He actually can't see out of it. He's an older gentleman with a history of diabetes and high blood pressure, and when getting out of bed, he actually tripped and hit the side of his bed table. And this is what you see when you put a tegaderm and put surgery on. Normal or not normal? Absolutely not normal. What can you say based on this? Is it possible to turn down the front lights, enough back lights to maybe see a little bit more? Just join, say, oh, that's excellent. I don't know if it's too dark. There's nothing in between. Okay. So, what do you see? What can you, just call out what strikes you as not normal based on all the ocular ultrasounds you have evaluated?
Vitreous chambers and nice and black.
Yeah, so something that's typically black and hypoechoic and homogeneous is now heterogeneous. What else? Someone said it's smushed, and someone else said, yeah, I'm not quite seeing the anatomy that is. Yeah, there's a complete disruption of the anatomy. And so, similar to MSK applications, we do the comparing and looking at affected to unaffected. So the bottom image is your unaffected, and the top image is your affected. So first, let's start at the unaffected. This is a really nice looking eye, and you'll see this today at the bedside. Here's our nice homogeneous hypoechoic vitreous chamber. We actually see an anterior chamber right here. Okay, we can see the iris and a piece of the lens. You see the nice back of the eye. You can actually see this structure back here, which is the optic nerve sheath diameter. We'll talk a bit more about that. And here, you guys identified everything. So it's heterogeneous. We've lost our anatomic structures. There's flattened chamber. So what's your diagnosis? This is a globe rupture. So depending on where you read, having a globe rupture is an absolute versus a relative contraindication of performing ocular ultrasound. However, I obtained permission, and I actually reasoned, truly, that by putting the tegaderm, I was actually maintaining some of the aqueous humor that was actively coming out of his eye. So this is not rocket science. It looks as you'd expect it to look sonographically. And this gentleman I called ophthalmology emergently, told him that I had someone with a ruptured globe. We gave him antiemetics, we gave him pain medications, we gave him antibiotics, and they didn't take him to the operating room for another 12 hours. So even what we're taught in emergency, that is an emergency, our consultants are usually the ones that decide the time and place for intervention. Okay. So you guys know that I think of like sort of visual images. So I want you to think of like kelp or seaweed anchored down at the bottom of the ocean floor. And it's sort of waving in the water vertically, and it's maintaining its vertical shape. And it's thick and ribbon-like, almost like Christmas candy from the 1970s. I don't know if you remember that Christmas candy. I used to remember it's nice, pretty colorful. But when you think of this image, you want to think of this ophthalmologic finding. And this is a patient that's presenting with painless loss of vision. Okay, normal or not normal? Not normal, okay. And what part of the eye are we seeing something? Yeah, so this is the vitreous chamber. And so your focus question, is there something in the vitreous chamber, yes or no? The answer is yes. And so, for novice level, that's it. You're done, call ophthalmology. But you have more experience, and you're better than that, and you want to be better than that. So this is a thick ribbon-like structure. It's tacked down at the optic disc near the macula. And it stays vertical as the patient is moving their eye to the right, to the left, to the right, to the left. What's your diagnosis? This is a retinal detachment. So memorize this picture, burn it on your brain. This is a retinal detachment. And this is often difficult to discern from a vitreous. And quite honestly, you don't have to necessarily make that call. You just know that you need to call ophthalmology or get them close to follow up. But this is what a retinal detachment looks like. It's thick. It's ribbon-like. It stays tacked down, and when the patient moves eye right, left, relatively speaking, it stays vertical. Think of kelp at the bottom of the ocean floor.
So
So is that tacked down around the optic disc? Is that where it's tacked down, or what's that? Where is it?
Yes, it's
Yeah.
the plane that we're in. We're not seeing
Yeah.
sort of the connection, but I believe there's another one coming. Okay, next patient is coming in with not acute loss of vision, but progressive loss of vision. And I want you to think of like socks in the washing machine, swishing around, swishing around, swishing around. And this is something that you're going to see a lot of once you start actually performing these. You'll see a lot of them. So, normal or not normal? Not normal. What chamber? Vitreous chamber. So these are socks in the washing machine going back and forth and back and forth. What's your diagnosis? This is a vitreous detachment, and often when the vitreous, the thin reticular layer of the vitreous catches, it bleeds. So you're actually seeing gray where it's typically black because there's hemorrhage. So often vitreous detachments bleed, and so you're seeing vitreous hemorrhage in here too. And in terms of what you do next, you're still going to call your ophthalmologist colleague. This is much less of an ophthalmologic emergency. And if you start scanning your hypertensive diabetics, you will see this very, very commonly. And one of the cues to seeing it is if you turn up the gain a bit, you'll really see it. Any questions or comments?
I have a question. When you sort of refer these patients to ophthalmology and you basically say your findings on ultrasound, how familiar are they with the basically ultrasound findings?
Great question. I think in the teaching environment, in the academic settings, the ultrasound actually they were the early adopters in a certain way. They used A mode, which is called amplitude mode, and then it went out of vogue, out of fashion. In fact, I'm not even sure, I'd love to see an A mode machine. And now it's back in vogue. So we actually have our consultant registrars ask for the machine, and it's part of their evaluation now. So younger physicians in training, very familiar. Older physicians, I don't think it's in their toolbox. Yeah, great question, thanks. Okay, so this is another socks in the washing machine, and you can see another distinguisher between a retinal and the vitreous is when a patient with vitreous moves their eye to the right to left, it won't always stay vertical, and you actually see the membrane floating horizontally as you did in the previous video. Okay, think lifesavers. Now, your patient is coming in with the eye swollen shut. You've already evaluated for the extraocular muscles, but you're really concerned is the pupil reactive. And when I was in training, we didn't have ultrasound, so we would actually pry open the eye and then try to quickly put the light in to see if the pupil reacted. And I venture to say that people know what I'm talking about. They've perhaps done that too. So this is how you look for pupillary light reflex. This is another one of my trainees, and I'm holding the probe in a coronal view. And you don't have to do a direct light over the affected eye by the conceptual light reflex. If you with a closed eye, shine a light in the opposite eye, you will see that pupil reflex, that pupil constrict. I find the coronal hold with the probe almost on the cheek, almost like a subxiphoid view, will get me what I need. There's a case series of people holding it in front. It's a little bit dependent on patients' eye sockets and how their eyes are set in their face. It varies greatly depending on someone's face use and facial structure. Okay, and this is what it looks like. It looks like a lifesaver. Look at that. And you can see constrict. Actually, this was not one. This is one just for you to look at the lifesaver. The next one will look at constriction. And there it is. It's a real crowd pleaser. People love it. You'll see we'll do it at the bedside. It's a real crowd pleaser. Yeah. And there's some case studies and publications that talk about putting M mode over it. You actually see the M mode. But again, you can see that. Yeah. And sometimes if you can't get an actual good view of the pure pupil, you can actually just see the iris constrict, and you'll see the length. Yeah. Yeah. It's a fun one. Who said it's just about the vitreous chamber? So here's another one, a little bit more subtle, but you can see that there's constriction.
Yeah, you don't need to see it all.
What did you say?
I said, yeah, you don't need to see it all.
Yeah.
Right. Yeah.
All right, it's very angle dependent. Okay, next, think of a monocle. This is like a bucket list, like one of those things like one day I'd like to see. Actually, the global lecture was like that too. No disrespect to the patient, it's a horrible situation, but it's one of those of what does this look like sonographically. So this is someone that was punched to the eye. And what's your diagnosis? Yeah, this is a traumatic dislocation of the lens. And you can see it sort of goes too fast, but you can actually see the full round circle that is the lens come in here and then out, in and out. And depending on the plane at which you're scanning, you'll see either a sliver or you'll actually see the full monofocal full lens. You don't see this often, but it's pretty distinct. There's obviously something in the vitreous chamber that's not supposed to be there, and this is what a traumatic lens dislocation looks like. And this is it in another plane, and there you can really see it looks like a circle. Okay, so what about the optic nerve sheath? So just like the IVC and as the holy grail of non-invasive monitoring of fluid responsiveness, everybody thought the optic nerve sheath diameter and measuring it was really going to be our answer to increased intracranial pressure. And I guess my summary of the literature is it really hasn't panned out to be that fantastic and to really do much for me in my practice in terms of care, diagnoses, etc. It's cool, and we will certainly measure it at the bedside. But at the end of the day, depending on the studies you read, they'll talk about in adults, if your optic nerve sheath is greater than 5 or greater than 6, then you're walking around with increased intracranial pressure. And I promise you that if we were to measure, some of us are walking around with 6.2, 7 millimeters. So it really hasn't panned out. One of the best studies I saw came out of Mass General, and they basically evaluated patients that came into the emergency department with increased intracranial pressure, who then went directly to the neurosurgical ICU and had a bolt. And they were able to correlate the width of the optic nerve sheath diameter with their pressure on bolt. But it didn't necessarily change management right there and then. You could imagine scenarios if you're in resource-limited settings without consultation, without CAT scan, without fill in the blank, that perhaps it would make a difference. But truly, it hasn't panned out so much in these experiments, and there's even a meta-analysis. And they're still even figuring out what the growth curve is, or what truly a child's nerve sheath should look like versus an adult. There's not agreement about where you measure it, whether in your sagittal plane or your transverse plane, but it's still worth looking at. And there are case reports that talk about, papilledema, you'll see thickening, and you'll see a little nipple right here because there's increased pressure. So you want to find your optic nerve sheath where it really abuts the back of the eye, the retina, and you freeze your image, you measure 3 millimeters back and then straight across. And even then, where I measure it may be different than where Kian measurements, which will be different than where Andrew measures. So it's a bit subjective, almost like your CBD or your anterior wall of your gallbladder. But this person had a measurement of 5.4 millimeters, and this is one of our medical students who had no headache and had no indication of increased intracranial pressure. And this is just a video showing about finding it. And I basically will just scan through and try to find my best area for where I see the optic nerve sheath coming right to the back of the eye, to the retinal layer. And we can measure this at the bedside. All right, final, this is a piece of literature I thought I'd talk about. So many of us that have spoken with you for these 3 days, we're all medical educators, and we're always thinking about ways to be effective as educators. And a lot of us participate in simulation because we're often performing exams or learning how to get better at exams using sensitive parts of the body that are hard to really study and practice on. So we came up with a contest for our registrars. It was a simulation contest, and we had 2 very, very creative residents that came up with an eye simulator to evaluate ocular ultrasound. And these are widely published and available. And if you're at all interested and you're all in a teaching environment and want to start creating phantoms, they're not expensive, and it's a lot of ingredients that you can get right at your grocery store. So what they did is they used the plastic container that you find at an old bubblegum machine, or like the toys that you find outside the supermarket, at least in the US, and they used that as their mold, and with their mixture of gelatin and Metamucil, they formed a round eyeball. And then they used simple things like a scalpel and an EKG lead sticker, and they were able to create some pathology. So here's the back of the EKG sticker, which crazily enough looks like an optic nerve sheath. And you'll see a picture of that. By putting a cut using a scalpel, they were able to create a retinal detachment. So here we are using our high-frequency probe and scanning. So this is the eye right here. This is the back of the eye. We'll do some closer-up images. So there's the lens, there's the vitreous, which isn't as black as you'd expect it to be, but it's metamucil with gelatin. There's the retina, and then there's the nerve sheath that was created just by putting that button sticker of BPG in. There's a little attachment. And we did an unofficial, non-IRB approved study at Resident Conference, and people said, yeah, like I'm much more comfortable now because we were able to talk them through looking at two planes, getting an appreciation of the anatomy, how to measure the diameter. So any sort of safe education, creative environment that you can create helps people feel more comfortable. This is a vitreous hemorrhage that I think they just put Elmer's glue right in the middle of it, and it created this sort of, heterogeneous disturbance. Here they just put I think it was a small bag of saline behind the eyeball when they placed it on the table. It created a little hematoma. Retroorbital hematomas, there's a case report about a woman that came in, she had trauma, and she had the shape of her eyeball looked like a guitar pick because there was blood outside pushing in, and when that hematoma was relieved, the guitar pick came back to be like the shape of a globe. So you find case reports, you run these eye findings, and that's all I have for you in terms of point-of-care ultrasound of the eye. Thank you.
Any questions for Resa?
Do you ever use it with pseudotumor idiopathic? Do you think there's any role for it?
So again, there have been case reports that with patients coming with pseudotumor cerebri, I think it was Stone that did
It's Stone,
it.
yeah.
Basically,
Yeah.
if you look, it's going to be a bilateral process, so you'll see a wide optic nerve sheath. You'll see it look like a nipple right at the tip, and then they did a pre and then a post LP, and the optic nerve sheath went down, and that nipple sign went away.
Yeah.
So it makes sense physiologically. You're like, cool.
Yeah. Is anyone like adopting that as a?
I don't think so.
Yeah. Still in revival.
Yeah.
I was doing it for pain muscle fusion, which obviously is not that many in an ED, but you always have runs of these rare things.
Yes.
And then actually I got quite excited because I saw a calcific structure behind the retina, which is about 1.2 millimeters with a shadow behind it, right, sort of very, very central. And I thought, well, this is a calcific embolus in a retinal artery, right? I wish in retrospect I had put colour flow on it to see if it was actually absolutely in line with the vessels going in and out of the eye. I sent it off to the eye and ear images to their sonographer to can you verify for me that that's what I actually saw? I didn't actually follow up the patient. Unfortunately, they never got back to me. But I have seen a few descriptors that you occasionally will see a calcific embolus in a retinal artery, so I got quite excited about it at the time.
I mean, all these applications that you've learned about over these 3 days, they build on. They start with a simple question, and then you know your anatomy and physiology, and you know your pathology. So you're the best ones to kind of take it to the next level and start making these diagnoses. Yeah. Thank you.
Any other questions?